Okay, thanks again, Ricardo. I'll make a start. And as you said, this will have some segue on from the discussion we were having before lunch. So these are my disclosures again for those who missed them the first time round. So this talk, I guess I'll talk a little about what I consider to be a wide-necked aneurysm to start with. I'll have a little bit of discussion about convergent and divergent technology, talk about adapting one's strategy to the particular situation you find yourself in with a particular aneurysm, and give some case examples. So before I kick off, I've been asked to talk about when I use what, and that is when I use what. So this is a purely personal experience, anecdotal, and for the purposes of this discussion, I'm going to pretend that open surgery doesn't exist for aneurysms. So when we talk about a wide-necked aneurysm, we really need to ask what's the significance of labeling something wide-necked. And really, there are two reasons we think about this. One, it really predicts the need for an assist device if we're treating the aneurysm, and it also, to some extent, predicts the risk of recurrence because the neck is possibly not as well controlled as it is if it's a narrow neck. And of course, there's angiographic definitions, there's aspect ratio, there's neck width, which may or may not have some meaning in some clinical contexts. But there's also a more practical definition. And from my point of view, I consider a broad-necked aneurysm or a wide-necked aneurysm to be one that I can't get a coil into. Also a more practical definition. But I also put in that same bracket of aneurysms that I can't get a catheter in without an assist device, because they're difficult as well. And I mean aneurysms like this that are offset onto a branch with a difficult angulated neck, because often these require an assist even though the neck itself would appear to be on the surface of it quite favourable. So practically speaking, I use both approaches. I look at the width of the neck, I look at the aspect ratio of the aneurysm, but I also look at how difficult I think it might be to get in, and I do some measurements. But broadly speaking, the necks of aneurysms fall into a few categories. There's the ones that are more or less circumferential with a fusiform type pattern. And these ones require a local vessel reconstruction. So just getting the neck of these is often not enough because there isn't much of a neck. You actually need to rebuild the vessel in that local segment. Some aneurysms have more of a longitudinally wide fish mouth type appearance with a long neck along the axis of the vessel. And these often require support of an intrasaccular construct, whether it be coils or a web or similar. And there are some that are both circumferential around the vessel and long. And these can occur at bifurcations or in the paraclinoid segment, for example, where you might need a segmental reconstruction. Now, when I'm treating any aneurysm, but particularly wide-necked aneurysms, I think it's important that everyone, that we have a plan A, a plan B, and a plan C, and be prepared to adapt your strategy to the case at hand. And vessels, to me, are a little bit like marriage. You know, they're a little bit different once you're in them. So you need to be prepared to change and adapt once you start treating your aneurysm. But in general, I'd always favour a simple approach over a complex approach. I'll always prefer to do something with a device that I'm familiar with rather than something that I'm unfamiliar with. Of course, I'll always try and do something that's durable rather than less durable for the patient. And if I adhere to those principles, generally speaking, I'll end up with something that's safer rather than riskier. So just to diverge a bit onto this discussion about convergent and divergent technology, I've given a lecture similar to this at other meetings, but we'll all remember from our biology days something like this, the Linnaean chart of evolution and the rapid explosion of organisms during the Cambrian Explosion. And we've seen something similar. We had our primordial slime back in the 90s with the evolution of the detachable coil. And then we went through a series of new devices coming out quite quickly after that. We had some temporary neck bridges in the form of balloons. We had some permanent ones in the form of early stents. And even the intrasaccular devices started to evolve. We had bioactive coils, we had gel coils, we had even liquids for a time we used in aneurysms. And the intrasaccular devices have really kind of converged or evolved into these devices that we see today. The temporary neck bridges, we've got balloons, of course, in various shapes, sizes and forms, and we've even got balloon-like stents or stent-like balloons, crossover type devices, whichever way you want to think of it. And the stents themselves have diverged into a multitude of different devices, some which are very niche and designed specifically for tricky bifurcations, others that braided, and others are laser cut. So there's a wide variety of devices. And in all, what that means is we've got over 20 devices that we can use for any particular broad-necked aneurysm, which, I come from quite a high volume centre, but that leaves even me feeling a bit like Livingstone in the jungle at times. I'm spoiled for choice, and often it's hard to know what the right thing to do is. So that really comes down to a discussion a bit about experience, and this is what we were talking about before lunch. Experience, it's all very well to do 50 aneurysms, but if you're using 50 different techniques, do you actually have experience? So I think it's important to put some numbers around that. And where I come from, we've got about 40 neurointerventionists in the country. That's going to expand by about a factor of half to 2/3 by 2025. But when you do the maths and look at wide-necked aneurysms, in effect, we're looking at people treating about 20 wide-necked aneurysms each per year in Australia. Now, some will be higher than that in the high-volume centres, some will be lower. But the question then becomes, is it safe to use 10 or 20 devices to treat 10 or 20 aneurysms? And this will have some bearing on the later discussion. So to make procedures safer, we can do a few things. We can increase case numbers, which, unless we embark on rapid immigration, is going to be a problem. We can't really just increase case numbers. We can limit operator numbers, and we've seen how effective that is here in the US. We can improve the device ease of use, and the companies do a great job with that, but that has its problems as well. But possibly most importantly, industry can make devices multi-purpose or very widely applicable. So things like the dual lumen balloons, where we can put a liquid or a coil, do a test occlusion, we can do a lot of different things with these devices. So in general, in my practice, I try wherever possible to use multi-purpose and flexible devices over the niche devices, so that I get a lot of experience with 2 or 3 products rather than a little bit of experience with 20. So this is not going to be a discussion about every single product you can use in a wide-necked aneurysm, but I don't have experience with most of them because I've got a very narrow range of devices that I use in almost all cases. So back to the discussion about adapting to our circumstances. This really applies not just to the aneurysm, but to a few things about the patient as well. But the first thing is, of course, is the aneurysm ruptured or unruptured, and obviously the goals are different. So priority 1 in a ruptured aneurysm is to stop the aneurysm from rebleeding. Whereas in the unruptured case, your first priority really is to have no complications. So you've got to do absolutely the safest procedure possible in the unruptured setting. And obviously, when you're talking about ruptured and unruptured aneurysms, the options are slightly different in that there's a slight steering away from stents and flow diverters in ruptured aneurysms, whereas you have a full range of kit at your disposal with the unruptured aneurysms. Location of the aneurysm also has a bearing. For example, sidewall aneurysms will tend to be less favourable for things like the web. Bifurcation aneurysms will tend to be less favourable for flow diverters in some cases. And whether the aneurysm is proximal in the circulation or distal in the circulation will also have some bearing in that using bigger catheters to get into smaller vessels is potentially more risky. What about the patient? Well, obviously in an older patient, patients with comorbidities, these guys will have a lower tolerance for anaesthetics and for complicated procedures. And often we're not so worried about durability in an older patient. We're more worried about protecting the dome of the aneurysm rather than getting a perfect angiographic result. And of course, in older patients with a limited lifespan, long-term antiplatelet use is less of an issue. In younger patients, durability is perhaps more important. Long-term antiplatelets can be an issue, particularly in young women who can have terrible menstrual issues with the second agent. And social factors come more into play in younger patients. Often they've got children, they've got family milestones coming up, and it's important to get them through their treatment and rehabilitation with that in mind. So just a couple of examples of patient-focused care. We'll come back to this case, but it's a 72-year-old woman, incidental MCA aneurysm. She's got mild airway disease, and she's got a past history of peptic ulcer, but she's otherwise well. So she's probably got a 10 to 15-year life expectancy. She's very anxious about her aneurysm. But in her, maybe we don't treat at all, but it's a bit irregular, and she's very anxious. But the priorities, if we are going to treat, will be to protect that dome and those little daughter loculi. And because of her peptic ulcer disease, we don't want to give her any antiplatelets, which from an endovascular point of view may be a problem. It's about 9-10 millimeters. Yeah. This other example is a 44-year-old man. He's a meth user. The day before I treated him, I found out he's the father of one of my son's school friends, which is very thankful to my wife for telling me that at 10 o'clock the night before I treated him. His aneurysm had grown from 2 to 7 millimeters in 2 years. So, this guy's got some social issues, but the priorities here are to protect him, and obviously he's going to be a compliance issue with his meth use. So, again, we want to avoid antiplatelets. And this is a terribly difficult endovascular case with that origin off the anterior temporal artery. But again, for the purposes of this discussion, we're pretending open surgery does not exist. So my approach when I'm dealing with these patients, if it's a ruptured aneurysm, of course, I'll straight coil or balloon coil wherever it's possible. I will use Webb for suitable cases, but as per the discussion before lunch, I do have reservations about the device. I'll use it if there's very difficult branch access for a balloon, and if there's a nice straight access for the delivery system. But I think there's a discrepancy between how easy the device is to push out the end of a catheter and how easy it is to judge where and when you should be using it and how to size it and where it should be used. And as per my earlier talk, if it's an appropriate case and it's really untreatable by other means, I'll use a pipe shield and aspirin. So just an example, 76-year-old lady, not in terrific health, WFNS2, she's got a wide neck basilar tip aneurysm. It's not a perfect angiographic result. There's only really 2 angiograms because it was all done under 1 inflation with 4 coils, but that's enough to get her through probably for the rest of her life without too many worries. So it's just a simple balloon coiling. This one I showed in my earlier talk. This is a 56-year-old guy with a really horrible blowout of the back wall of his carotid. He got a pipeline shield and aspirin. So we're tailoring our treatment to both the aneurysm and the clinical status and needs of the patient. With unruptured aneurysms, it's a little more complicated. Obviously, sidewall aneurysms tend to lend themselves more to flow diversion. We generally use pipeline as our go-to for the proximal vessels, and we use Silk Vista Baby for the distal vessels. So it goes through 17 catheters, so it's a very nice low profile and easy to deliver system. For aneurysms with bifurcations, we err towards stent and coil. We haven't really looked seriously at the Webb as a durable device for that indication, but obviously time will tell. We generally use the Leo Baby at bifurcations. We don't tend to use laser cut stents alone. The recurrence rate's really not acceptable in our view. For T or Y stent constructs, though, we will use a laser cut stent like the Atlas into one branch, but we'll always use a braid in the other, either the Leo Baby or the Silk Vista Baby. Just touching on our bifurcation aneurysms and braided stents, we actually first got access to them in 2011 after we'd had a few recurrences with the laser cut stents. And we decided to put in an ethics proposal to collect our data prospectively, which we did, collected the usual stuff. And our fellows published this was their second paper on this. This is our long-term follow-up of this cohort, came out in Janus last year. And to summarize, I won't go through each of the figures, but we had very low clinical and technical morbidity. Only 2 patients had any neurological disability at all at 18 months. We saw, interestingly, improved aneurysm occlusion over time. So whereas only about 50% had complete occlusion at the time of treatment, 97% had complete occlusion by 3 years, which is probably reflective of the flow diverting or flow alteration by the braid at the aneurysm neck. We also had very good durability at bifurcations, so 94% occluded by beyond 3 years, and all of them really safely occluded. The remainder are all Roman Roy 1 at 3 years. There's an example of a T-stent construct. It's a 44-year-old guy, smoker, a bit unreliable, but a nice guy. Got his T-stent, got his coils, and you can see his 30-month follow-up there at the bottom right. Very nice and durable result. He's had an MR recently, which I don't have. It was on paper, but it's still durable at 5 years. 64-year-old T-stent construct, 2 Leo babies, and again, the 18-month, very durable result there. This is a case I did at Link, in fact, in 2016. There was some discussion whether I should have used a flow diverter here, but this is a nice case of tailoring it to the patient's needs. So it's a giant basilar aneurysm. She'd ruptured in 97 and had attempted surgery at the time. She had a couple of clips there, but she sustained a perforator injury. She's been wheelchair bound since, but she's independent. The priorities here for me, I'm the guy who's got to see her, not the people in the room at Link. My priority is to avoid any further perforator injury because she's got one arm that works and she's fiercely independent. So there was some discussion about flow diverter, but obviously, even though we use it in the posterior circulation in Australia, there is a slightly higher risk of perforator injury using a flow diverter rather than a simple braid. So I elected to put a Leo baby in coils. And this is a nice example where you can see in the middle picture, I deliberately left a little bit at the base of the aneurysm. I wasn't overly concerned about chasing that, having with our experience with the device. And sure enough, at 18 months, you can see that that's completely occluded and she's got no residuum there. This is a 42-year-old lady. So this was shortly after we got access to the Atlas stent. And this seemed to be a good candidate for a Y stent using the Atlas, and that's what we did. So you can see when I say we, remember my pronouns. So there's two Atlas stents in there, and a pretty nice coiling. The catheter was a bit jammed in there, and we couldn't really get that bottom pocket. But I wasn't overly concerned with that based on our experience with the braids. We thought that would probably close. And that was 1 month post-treatment on the left. And on the right, when she came back to me with her MR, you can see a big flow void at the medial edge of the coil mass and pretty florid edema in her white matter and at the front of her peduncle. So I was a bit worried about that, and she was off prasugrel at the time. So I took her to angio, and sure enough, she's got significant decoherence of the coil mass, and she's got regrowth. It's not coil compaction; it's growth of the aneurysm in that interval. So I took her back, and I put a 17 catheter round into that Frontal H lay 2, and my thinking was repack and put a braided stent in, because we know from our experience that the braids will work. So we put the braid in and repacked it. And you can see on the left her second procedure MR and on the right the post, and you can see the flow void at the edge is gone and the edema is resolving already. So we still have up our sleeve a flow diverter if we really want down the track, but I think the braid will do the job. So not too long after I treated her, and this lady came along with worsening left temporal headaches and this big aneurysm, and she was very keen to have this treated endovascularly, and to be honest, I was quite keen to treat it endovascularly. It looked interesting to me. The difficulty obviously was going to be where that arrow is, the access to that M2 outlet inferiorly. So the plan we put together was to access it around the world with a catheter, take the slack out of the catheter. I'm sure we've all done that. I call it the toilet paper technique, little jerk on the catheter. You get one piece of toilet paper rather than the whole thing. It seems to work quite well. Deploy an Atlas as the first limb of the Y into the inferior division, then put the catheter back in, because my intention was to use a Silk Vista baby as the second limb, because I really wanted this to be gone. It doesn't show on the 2Ds, but the aneurysm at the back is very broad. And then to reaccess with the second catheter into the M2, the superior M2, deliver the Silk baby, and then coil. And just to show you the access, it was really pretty straightforward. The whole procedure took about 40 minutes. So there's the access into that M2 out there. I'm not sure how well this projects. It's usually pretty visible. You can see the Silk Vista here, part deployed, and you can just see it wasting a bit as it comes through the Atlas about there. I'm not sure if you can see it there. So the Silk Vista is just coming out there. That's the construct on the Dyna CT, or after the stent deployment. On the right, you can see the final coiling result. That little loculus down the bottom is part of the same aneurysm. Coils just wouldn't go into it, but I suspect that will go away with the flow diverter. But she's only about 3 weeks out, 6 weeks out now, so I haven't got a follow-up yet. This is an interesting lady, 66. She had a subarachnoid in Croatia when she was visiting her relatives there, and she was lost to follow-up for 2 years, and then came to see me when she returned to Sydney, and she was found to have 2 new aneurysms at that follow-up, this tiny little P1 and the little pica there on the left. And I don't know about you, but I felt that P1 would be a nightmare to treat endovascularly. And I thought the pica might be easy to coil, but then I took it to try and coil it, and it would not accept a coil. Everything was falling everywhere, into the pica, into the vert. It was just impossible. So I thought an approach with the Silk Vista baby into that P1 would be appropriate. And you can see the positioning of the Silk Vista. The back end of the stent is about here, about to be pushed out of the catheter, just there. And when we deploy it, you can see how flush it just shortens right up to that P1 origin and sits nicely across there. And then turned our attention to the pica aneurysm, and it actually proved impossible to get into the pica from below, from the left. So we switched to the right and came from the right down the pica from right to left, and then delivered the silk vista baby there. So you can see it going from narrow and constrained in the pica to nominal diameter in the vert. And this is the follow-up at 6 months. So the aneurysms, both aneurysms are gone, and the stents are nicely patent. So back to our original lady, the 72-year-old, the one where we can't give her antiplatelets or don't want to because of peptic ulcer disease. You can see what I'm doing here. I hate to say it, but I'm putting a web in this thing. You know, I'm going to get shot here in this room for saying that. But you know, there really aren't many options, in all honesty, for a lady like this. I mean, in fact, she's got 3 M2 divisions separately sticking out of the top of the aneurysm. It's a real blowout at the MCA bifurcation, and this big one inferiorly. So the green line there is depicting where we want the back edge of the device to land. And in fact, it did sit very nicely. This is about the 3rd case I'd ever done, and it actually landed not through any good management or good luck, but you can see the way it's sitting on the unsubtracted view on the right, preserving all those M2 branches. And on the left, you can see how it's already excluded the dome. So it's early. We'll get some follow-up. If it recurs again, she's 72, so it's not a disaster. If it recurs, you know, she'll probably be all right with that for the rest of her life. And this is our Meth guy. Again, we want to protect his dome. What we really want is to get a result like that, a clipping-like result with this guy. And again, it would have been a really hard stent coil and a really hard balloon coil. But in this case, the web actually sat quite nicely. You can see it refashioning that little segment of the vessel there. So, you know, that was a really nice treatment, I think, for him, for a guy who's likely to disappear into the wilderness for a while and who was really not up for a craniotomy. It was hard enough to get him into hospital for this. So to wrap it up, you know, there are a lot of different ways to treat aneurysms with difficult necks. I try and keep it to a minimum and keep it simple. But you do have to tailor the treatment to both the aneurysm and the patient. You know, you've got to take into account whether the aneurysm is ruptured or unruptured, where the aneurysm is, and how easy it is to get to, both endovascularly and open, the age of the patient and their social circumstances. Again, try to avoid using too many devices, and I think that's particularly apt for low volume centres, particularly if you're not doing many aneurysms. It's really important you stay familiar with a few devices and use multi-purpose devices wherever possible, and keep it simple as wherever possible. And I think our colleague from Shanghai yesterday summed it up beautifully. So I put this back in because I think it's really important for everyone in the room, not just low volume centres, but it's really important you do one thing a lot of times rather than one thing a lot of times. No, a lot of things one time rather. Anyway, on that, I'll close up. Usual acknowledgements to my colleagues in Sydney. I'll be seeing them all in a couple of days and back on call. Thank you.
Any questions for Jason? So I have one for you, Jason. How many aneurysms, and please, that's not a sin, we still do that in this country, in Brazil. How many aneurysms get clipped at your center in Sydney every year?
I work across 2 centres, and they're a little bit different. So the centre in the east of Sydney has pretty expert neurovascular surgeons. The centre in the west has one very good neurovascular surgeon, but he's not on call all the time, obviously. So that has an impact on how things are treated. In the east, we treat about 125 aneurysms endovascularly a year, and probably 30 get clipped, 20 to 30 get clipped. In the west, we'll do about the same number endovascularly, but probably only 10, 15 get clipped.
So if you would have had somebody, if this patient would accept a clip, he would be...
Yeah, look, I mean, we tend to lead the discussion because we treat more aneurysms, and we've got more experience. The endovascular guys have more experience than most of our clipping colleagues. It's just the way things are going, and I'm sure that's the same here. But we take the time to have the discussion about every patient, whether it's a narrow-necked basilar tip aneurysm or a broad-necked MCA. We'll sit down and have a chat about it, even if it's for form's sake. It's important we do that. I think we owe that to the patient.